Morning, afternoon, evening, everyone. So as Stephen has mentioned, my name's Daniel Cehic. So I am a cardiologist in Australia, trained originally in electrophysiology, and about 4 years ago at ESC in Rome, I went and listened to Daniela Cardinali talk on Cardio-Oncology, and basically thought that that's what I'm going to be doing. So I've effectively in the last 4 years transitioned over with cardio-oncology being a major focus, and I happen also to be the Chief Medical Officer for GenesisCare Cardiology in Australia. So GenesisCare is a large cardiology organisation in all the mainland states. And we're actually a much larger oncology organisation with oncology in Australia, England, Spain, and now also the US. So it's a nice fit for us to have cardio-oncology. And one of my remits is to establish cardio-oncology practices around the country. And if I move to my next slide, if this works. There we go. So that's so I'm based in Adelaide, and I put this slide up because most people don't know where Adelaide is. The building there at the bottom left is my consulting rooms on the second floor. But I also practice and have a cardio-oncology clinic, mainly in radiation risk prevention, longer term management in Sydney, which I go to once a fortnight, which is quite a long distance practice because Sydney is about 1,000 miles away. But there's not an abundance of cardiologists in Australia that are interested in cardio-oncology. So we do spread ourselves a bit thin. Now, the talk today, it is a case study. The case study itself is relatively short and is more as an entree to discussion of neuroendocrine tumors and carcinoid syndrome. And it'll probably go for about 30 minutes or so. So there'll be absolutely plenty of time for questions and comments at the end, and perhaps even an early minute, depending on how many questions there are. So the case, Mrs. T.U. is a woman that I've seen only just recently, actually, and she was referred to me by her medical oncologist, and this is with the appropriate redaction. This is the referral letter in sum total. That's all we got for the referral. So in Australia, cardio-oncology is still a relatively nascent area, just getting acceptance by many of the oncologists who are building up trust. And so this is actually delightful that we've got the referral. So she's a 76-year-old woman who's been referred, having been seen a general cardiologist in the past, but this particular medical oncologist, as you've seen from the last line, wonders whether we should be managing her tricuspid regurgitation more aggressively than what had previously been planned by her general cardiologist. So she's 76. She really is otherwise well. She has a neuroendocrine neoplasia since 2010. She does have liver metastases and does have carcinoid syndrome. Her last urinary 5-HIA that we were able to retrieve from her oncologist rooms was elevated. This was done over a year ago, and she is treated with somatostatin analogues, and about 2 years ago had lutate therapy because of progressive disease. But she's actually asymptomatic from a cardiac perspective, apart from some palpitations, but these are consistent with ventricular ectopic beats and are not a major feature. She certainly has no signs of right heart failure, and certainly no murmurs are heard on auscultation. And her previous echo was done in July last year by an external group to us. And what you see highlighted there is the fact that she had normal right ventricular size and function at that stage, according to the report, moderate to severe tricuspid incompetence and moderate pulmonary incompetence. The rest of the heart actually looks pretty good, but so she clearly has involvement on the right side of her heart, and one would presume from her presentation that that's a degree of carcinoid heart disease. So we have repeated her echo, and this is a slightly poorly formatted conclusion from that report, and I'll show you the pictures in a moment. But essentially, it does show, compared to the last report, and we don't have the images from the last report, that it would appear she's progressive. Her right ventricle, which was previously considered normal in size, is now dilated. Her tricuspid incompetence has progressed and is now classified by the reporting cardiologist as severe, and her pulmonary incompetence has also progressed and now classed as moderate to severe. So just might show you some of these images. So it's parasternal short axis, and I'm not an imaging doctor, obviously, as an electrophysiologist, but I did ask my imaging colleagues to point this out to me, although I can read echoes a little bit. So the D-shaped flattening and what would be consistent with a dilated right ventricle on this view.
Certainly from an AP standpoint, Daniel, it looks like she's in normal sinus rhythm.
Yes, very good, Josh. Excellent. That is correct. She is in normal sinus rhythm. And this is her tricuspid valve. You know, that septal leaflet looks bowing, if not prolapsing, and but doesn't look sort of grossly abnormal, to be fair. But her tricuspid incompetence is significant, with my imaging colleagues telling me that's quite a broad jet and reaching all the way back to the wall, back wall, and would be classified as severe. I mean, they obviously do multiple other images and jets and things that I don't think are necessarily fruitful for this discussion. And then in a parasternal view of what I'm told is the moderate to severe pulmonary incompetence. So, where to from here? And it's a little bit of a rhetorical question. So this lady, in fact, I only saw within the last week. You know, we have a woman who's otherwise well, who's 76, who I've got moderately little information about in terms of her tumour and prognosis and grade, who is basically asymptomatic, but clearly has progressive disease if we believe the previous report and if we believe our report. And so what I thought I would do, unless there are any questions about the case, just do a bit of a brief overview of neuroendocrine tumours and carcinoid heart, and then tell you what I've decided to do as next steps. But I think this case is not so much sort of a dilemma diagnostically, but more a dilemma on when to intervene and what to do. Okay. So neuroendocrine neoplasias are a pretty uncommon tumour, but not rare. And the incidence is thought to be around 7 per 100,000. And the incidence is clearly seen to be rising. The graph on the right-hand side shows data from Cehic registry there in the States. And as you can see, the blue line is other malignancies or total malignancies, and that's relatively static. The yellowy orange line is neuroendocrine tumours, and that incidence is definitely climbing over the last few decades. And it's thought that this incidence is picking up because of increased detection, noting that often these patients have been missed for many, many years in the past, but awareness is increasing. And also it is felt but not proven that there is a true increasing occurrence of this disease, although the factors that are causing that increasing occurrence or presumed to be causing that increasing occurrence are unknown at this stage. They have a long history and they've had numerous names. Certainly when I was training, they were called carcinoid tumours and otherwise known as neuroendocrine tumours. And now they're collectively referred to as neuroendocrine neoplasms, and I'll talk a little bit more about the subgroups in a moment. But you know, people still, certainly I still hear people talking of carcinoid tumours and also NET. So uncommon but not rare. And the other reason they're not rare in terms of coming across them is that their prevalence is actually quite high. So they are thought to be about 40 per 100,000 population. And if you look at the graph on the right, which looks at gastrointestinal tract tumours, they are the second most prevalent tumour of that system. Second only to colon and rectum. And really one of those reasons, of course, is because they have quite significant long-term survival in many cases. And so these patients are around for a long time, and hence they build up their size. In terms of how they do, there is a grading system. Grade 1 is obviously less aggressive from the malignant metastatic or malignant potential rather, and grade 3 and 4 obviously worse. But you can see if you look at appendix, lung, rectum, colon, cecum, stomach, these patients can survive 10, 20, 30 years with these tumours in place. And so you can therefore see why the prevalence is moderately high. And the thing to note is that the grade of the tumour in terms of its aggressiveness and malignant potential is not actually correlated or related to the reason that it can cause problems. Which is its secretory potential, which we'll talk about a little bit in a moment, because that's obviously very relevant for carcinoid heart. So in the good old days, they were classified as per their embryological origin, and you'll see the graph on the right under foregut, midgut and hindgut, and certainly that's how I learnt about it in medical school and physician training. But they've gone through various iterations of classifications over time. They can be identified by location as outlined in that graph, which generally fits into their embryological origin, obviously. And they can also be described as functioning versus non-functioning, and that relates to their ability to secrete products. As listed on the right-hand side of this slide, and also they can be described as per which products they release. And serotonin is in red because that's probably the most relevant one for the discussion that we're having today. And this tends to come from the previously termed midgut neuroendocrine tumours, and these can be and frequently are low-grade tumours, so have a relatively indolent malignant course, and so can be around for a long time, which is relevant for the development of carcinoid heart disease. The whole classification system changed about 3 years ago, and it's just highlighted in a little graph, a little table there. I mean, I won't go into the grade in any depth because that is the remit of the oncologist predominantly. But that's just, when you're looking to discuss these cases with the oncologists and clearly looking at planning what treatments and management of the patients from a cardio-oncology perspective, it's clearly important to know what their long-term prognosis is because it makes all the difference about what we should be doing to their heart. So it's good to have an idea of what goes on. In terms of the treatment for the neuroendocrine tumours, this is not really anything but a reminder for me to talk to you about that. This slide is from a paper a few years old. Things have changed slightly since then, since the new classification, but essentially you can see there's really quite complex treatment regimes potentially with chemotherapy, with targeted agents, with surgery, and importantly with somatostatin analogues, and there it is really a bespoke treatment regime for many of these patients, and ones that can certainly change over time, given that many of these patients survive for decades.
Daniel, this is Dan Linehan from St. Louis. I was just, it seems to be my observation that it depends on the institution if there's an oncologist that's comfortable with this type of cancer. Even at WashU, which is a very big place, and the cancer center is really large, many of our patients tend to go to places that, like for example, there's an expert in oncology treatment of carcinoid in Iowa, and so they go from WashU to Iowa for periodic visits, or they go to the National Institute of Health in Baltimore. And I was just curious what happened in Australia.
Yes, look, that's an analogous situation, although we've only got a handful of major city population centres. So most would have treatment centres. So our big major cities, Sydney, Melbourne, Brisbane, Adelaide, Perth, really all have therapeutic options for these patients and have areas of expertise in each city, really. I might just give a plug. You might see, and one of the reasons I'm particularly interested in this, you might see that on the reference of that paper is my surname, but that's actually not me, because that's my wife, who's a medical oncologist, a nuclear physician, and she actually set up the neuroendocrine sort of treatment service for lutate therapy here in South Australia some 10, 12 years ago. And so, really, we're pretty fortunate that previous to that, our patients in Adelaide used to have to travel to other cities, as they did sometimes from like Hobart, but now pretty much all of the cities have a centre that will do it.
So you're riding on her coattails, is that what you're telling me?
I am riding on her coattails, Dan, and in fact, she is actually sitting next to me, listening to make sure I don't make a mistake in this presentation.
I love it, a multidisciplinary presentation. That's great.
Absolutely. In case I got any hairy questions about neuroendocrine, about the malignancy itself, I was going to pass her over.
There you go. Perfect. Thank you.
Okay. So the next step is the carcinoid syndrome that I wanted to discuss, and really what is now known as carcinoid syndrome was probably first described 130 years ago with an article in the Lancet, which shows an interesting description, obviously, of what was not really known then, but what is now clearly a carcinoid syndrome. And carcinoid syndrome is classically described as a patient having some or all of the cutaneous flushing, wheezing due to bronchospasm, or diarrhea with gut hypermobility. And about 30 to 40% of neuroendocrine tumours, it's felt, get carcinoid syndrome, although that number seems to be decreasing, and it's thought that this is in large part due to the somatostatin analogues that are now really quite a standard part of therapy and given early. Obviously, you need to be a secreting neuroendocrine tumour, usually to get carcinoid, and it is felt that the culprit is usually serotonin that causes the carcinoid syndrome. As the tumour products tend to be inactivated by the liver, it's usually a requirement for the patient to have developed liver metastasis before they develop carcinoid syndrome, although that's not always the case, as it can occur if you have extensive retroperitoneal involvement or tumours in other locations. But by and large, the patients tend to have liver metastases. The term carcinoid, I'm not a big history buff, but I don't mind delving a few years back. And the term carcinoid was coined in German by a pathologist close to just over 100 years ago. And a case of what is clearly carcinoid heart disease, although again not known to be so in 1930, is described in the Royal Society of Medicine proceedings from that date, with a picture from that article that shows this 31-year-old railway worker clearly having his cutaneous flushing, and certainly he was described as having features of right heart failure. So it's also called Hedinger syndrome, although I must admit, prior to preparing this talk, I'd never actually heard that term before, but that's after a pathologist, but it's not commonly used. Now, the pathology, the pathogenesis of carcinoid heart disease itself is not completely understood, but clearly relates to vasoactive substances and other substances released by the tumour, particularly serotonin, but a whole host of others are thought to potentially be implicated. And I won't go through that diagram on the right, but I think it just highlights the complexity of what goes on to lead to the plaque-like deposits, which are really the hallmark of this condition on the endocardial surfaces, particularly the right-sided valves, tricuspid and pulmonary, the subvalvular apparatus, and also the cardiac chambers. The picture on the right is obviously a resected tricuspid, well, not obviously, but it is a resected tricuspid valve, thickened leaflets and subvalvular apparatus, as described in that paper. And it's been shown that the plaque deposits are composed of a complex structure of myofibroblasts. There are smooth muscle cells, various matrix components, extracellular matrix, and endocardial cell layers. And as mentioned, 90% of cases involve the right heart, and that's because it is felt that the pulmonary circulation somehow, a bit like the hepatic circulation, deactivates the responsible agents. And so the left side of the heart tends to only be affected in patients who have a PFO, or have got, for example, a bronchial secreting neuroendocrine tumour that goes directly into the left side of the heart. Could not find an explanation, but it would appear that the plaques tend to deposit on the downstream side of the valves. So what I mean by that is the ventricular side of the tricuspid and the pulmonary artery side of the pulmonary valve. And the tricuspid valve tends to be affected predominantly by making it incompetent and regurgitant rather than stenotic. The pulmonary valve is reported to be able to suffer from both conditions particularly. So is it important? It is very important in patients who get it. About 30 to 40% of patients who have neuroendocrine tumours will develop carcinoid syndrome. So that's the flushing, the wheezing, the diarrhea, or the components thereof. And of those, about 20 to 50% develop carcinoid heart disease, depending on which paper and depending which era you look at. And again, it's thought that the somatostatin analogues, which came out in about the mid-80s, have declined the incidence or reduced the incidence of this. And in the mid-gut, so-called neuroendocrine tumours, the major, and these are often low grade, which as the previous graphs showed, have got 20, 30-year survivals often. The major predictor of outcome is the presence or absence of severe carcinoid heart disease. And the graph on the right basically shows the survival probability in a relatively small population. And this is one of the problems with carcinoid, is that there is very limited data and therefore decisions are often based, with imperfect information. But you can see that without carcinoid heart disease, there is certainly a much better prognosis than with carcinoid heart disease. And I guess, although we all see deterioration that can occur quite rapidly in any valvular condition, one of the unpredictable aspects of carcinoid heart that is particularly concerning is that you can get quite rapid deterioration. A number of papers have shown that. And as mentioned, once it is established, then the prognosis is poor. And it's felt that the valvular lesions in general, the feeling from oncologists that deal with this area are that the valvular lesions are really not treated aggressively enough. And there's reasons for that, and we'll talk about that in a moment. So there's a number of issues in dealing with carcinoid heart. And some of them include the fact that there is certainly no definitive diagnostic criteria. There are variable recommendations for screening and imaging, and whatever recommendations are put out, there's a little data to support why those recommendations are put out. And I guess, living in the world of cardio-oncology, that's something we're more comfortable with than interventional cardiologists say. In terms of the clinical features, often there are none. They may be absent or subtle, and even patients with moderate to severe tricuspid incompetence may have minimal or no symptoms. Certainly that is consistent with the patient that I've outlined. And about a third have no detectable murmur. And again, on this woman, I was not able to detect a murmur when I examined her, although it is fair to say that in this COVID period, we are tending to do relatively quicker examinations to minimise contact with patients. Obviously, as the disease progresses and we run into the hallmark features of heart failure, or dyspnea, fatigue, JVP elevation, obviously prominent V waves with the tricuspid incompetence, and then what would be considered pretty grim features of edema ascites and pulsatile hepatomegaly. But really those patients will be quite progressed at that stage. There's been a lot of talk of biochemical screening for risk of development of carcinoid heart. And it's interesting in the oncology literature, and I think this is what we see in cardio-oncology, where there is sometimes a divide or chasm between the oncology literature and the cardiac literature and practice, that certainly not so much now, but in some of the earlier literature, there was a lot of discussion about what tests should be done to select patients to be screened with an echo. Now, I'm not sure what it's like for the audience, but certainly in Australia, for most cardiologists, an echo is really considered part of a clinical examination and are frequently done. And so in terms of screening, the various guidelines like the NCCN in the States and others have criteria for when patients should be screened with echo or not. But I think, certainly my practice would be that these patients should be screened regularly, certainly yearly, and potentially even more frequently than that if there is concern that the disease may be progressive. And more recently, there is discussion over using biochemical screening for prognosis and diagnosis. And the two that feature most is urinary 5-HIAA. And now you'll remember that the last time this was measured on my patient is a year ago or just over, and was 700. And that puts her fair and squarely in the higher risk group for developing carcinoid heart, which obviously she does have. The urinary 5-HIAA, though, is a test that's quite cumbersome to do with 24-hour collection and is very dependent and interacts with various dietary substances and also some medications. And so the oncologists do it, but not necessarily all that frequently. It depends on the individual oncologist. The other biochemical screen is what we're more familiar with, which is the NT-proBNP, and levels of greater than 260 portend a higher risk according to the literature. So, that's a test that is potentially sort of useful, of course, as a marker, and perhaps to determine when to act. So in terms of the imaging, well, transthoracic echo is really the mainstay of imaging for this condition. On the left is a table which I won't go through in detail, but effectively showing all the transthoracic echo changes that can be seen, but it's effectively tricuspid and pulmonary valve most commonly, and then the right heart dilates, not unlike any ventricle dealing with incompetent valves of significant severity. On the right is a table that shows the scoring systems. There's been a number of scoring systems proposed. They're all pretty similar in their feasibility and detection, but looking at the articles, and with no disrespect to any of the authors, because some of these authors have been mainstays in the literature in this field, but really what they are is just scoring the tricuspid valve, for example, as mild, moderate or severe, but turning it into numbers 1, 2 and 3, and then adding things up. So certainly it's been done, the work's been done, but how relevant that is clinically is questionable at this stage.
So as far as blood tests are concerned, do you guys ever test chromogranin A?
Yes, I don't, but the oncologists do. I could actually hand you over to my wife, Dan, because she's actually in a much better position to give an answer to that.
Hello, Dan.
Hello. Nice to meet you.
Hey, you too, Dan. My name's Gabby. Yeah, look, we certainly do. There's a lot of discussion about which biomarkers you use. certainly in a screening capacity, there's a fraught with problems because of a lot of false positives because of people on proton pump inhibitors. But we have found it to be absolutely invaluable. It's a great way to evaluate response. And of the family of chromogranins in Australia, we choose chromogranin A. And obviously, if it's collected properly and you're mindful of false results, we have patients with their results in the thousands. And with response to whatever line of therapy, it's a very, very useful marker, but it doesn't really prognosticate for carcinoid heart. And I think one of the mistakes we've made, we've been doing this for many years, we found that 5-HAA collection was quite problematic. And so we kind of stopped doing it until we started to appreciate that it probably was right under our nose as a way to evaluate and try and find a way to prognosticate for these patients. So different markers, different roles, but certainly they both have a different role to play.
Great, thank you.
Indeed, thank you, because I would not have been able to answer that as eloquently. So other imaging, transesophageal echo, really looking for PFO detection, cardiac MRI if you want to get a better assessment of the pulmonary valve, which obviously is not often or not always well seen on transthoracic echo, and also a really good measure for RV size and function. Cardiac CT, probably mainly if patient was going to surgery to evaluate coronaries, unless you wanted to do an invasive angiogram. Nuclear medicine has limited role unless there's concern over cardiac metastasis of the tumour, which is uncommon but can occur. And ECG is non-specific, sometimes low voltages, but generally non-specific. And certainly my case today, her ECG was completely normal, and as Josh said, in sinus rhythm. In terms of the treatment of the NET itself, I certainly won't go into it, but as discussed, so how do you treat the carcinoid heart disease? Well, you treat the tumour first. The tumour is what is releasing the substances which causes the carcinoid heart. So control of the tumour itself by its metastases and control of the effects of its secretory agents are the cornerstone, and clearly that's all in the realm of the oncologists and critically important, particularly the somatostatin therapies. In terms of the heart, once the heart is starting to fail, if it's allowed to get to that point, as we all well know, treatment of right heart failure is problematic and difficult, and we have a relatively limited armamentarium. Diuretics, salt and fluid restriction, maybe there's some evidence for digoxin. There's certainly no evidence for much else in the world of right heart failure. So we have limited options. And hence why the whole issue of, and it makes sense. This is, as in most valvular lesions, I mean, it is a mechanical problem, and usually you fix a mechanical problem with a mechanical solution, which is valve surgery. Now, interesting table, what is listed there is table 5, which is from a JACC expert statement from a few years ago, talks about indications for valve replacement surgery. The bottom line there before hepatic surgery, that's to do when patients having aggressive resection or liver transplantation to try and deal with the hepatic metastases, and is a pretty uncommon reason to have surgery. And then the 2 lines is fatigue dyspnea leading to ascites and edema. So clearly, pretty significant heart failure if you start getting ascites. And then there's the issue of progressive but asymptomatic right ventricular enlargement. In the body of that JACC expert statement, in the body of the text, they do tend to lean towards only sending people for operative intervention that have become symptomatic, even though in this table they've stated that it's potentially for asymptomatic cases. On this slide, the other 2 tables, table 2, what's listed as table 2 is for the non-cancer population, and just a comparison of American and European guidelines for TR and treatment for surgery. And really, I mean, I won't go through them, and there certainly are some class 1 indications and quite a few class 2A, but you know, the carcinoid heart TR doesn't really fit into that very well, and so that's not particularly helpful. But you know, the table on the right, which is again in the non-cancer population, the blue line being New York Heart 4, and red and green 2 and 3 respectively, show that in a non-cancer population, tricuspid incompetence, if not intervened early before class 4, certainly forbids a pretty bad prognostic sign. So that's sort of do what I tell you, but yep, sorry, Dan.
You know, the one thing about, you know, asymptomatic, I mean, I think by definition, if somebody's having ascites or lower extremity edema, then they're not asymptomatic. And so I think the other thing is that, you know, you have to do some tests to explore their exercise capacity. So whether you do a 6-minute walk or a cardiopulmonary exercise test or something, to get an indicator of what they're capable of, because what people usually do, and I'm sure you found this, is most people just limit their activity to the point where they say they're not having any symptoms, but they're not doing anything either.
Oh, look, Dan, I think that's an excellent point, actually. Certainly nowhere in the literature is that discussed. And I guess that's one of the foibles of New York Heart or symptom classifications, is that you're quite right. People will often downplay. Certainly I find that in a lot of my patients that I follow with moderate to severe or severe aortic stenosis, who tell me they're completely asymptomatic with a mean gradient of 60. I find it hard to believe, but I think you're quite right. People do adapt their activities, and I do actually really like, nowhere in the literature is that mentioned, the 6-minute walk or stress testing, but I think that's actually a very sensible approach.
This is Joe. I've sort of evolved over time in a lot of these patients, and if you wait for symptoms, or if you wait for ascites and edema, you sort of miss the boat. So by echo, if people develop severe TR, even without symptoms, it's really an indication to fix it. And if you wait too long to fix it, the result is not good.
Thanks, Joe. Yeah, look, I would agree, and certainly, you know, again, I don't know what it's like elsewhere, but in Australia, and you know, when I was training some long ago than I care to remember, we were told, you know, tricuspid valves, they're not important really. You can do without them, and if they're leaky, that's just fine. But clearly, that's not right. And I agree with you 100%. And in fact, in my general cardiac practice, I've certainly have referred patients to surgeons for repair of or replacement of their tricuspid valves, mainly when, you know, they were going for, say, severe mitral incompetence, and they had a moderate tricuspid incompetence that, you know, I've often suggested that maybe they should fix both when they're in there. And sort of late, that's been occurring more frequently. So, but I think the general sentiment towards moving towards the more asymptomatic case is correct. And you know, these two groups, one from the UK, one from the States. Again, you know, the UK group, very small numbers. The US group, obviously larger, show that you know, somewhere between 30 to 50 or 60% of their patients from their series have been operated on with no or minimal symptoms. So that's, I think, the trend. And when you do operate, or when operation is performed, it's obviously usually it's because of tricuspid issues. and most would recommend, certainly in more recent times, that the pulmonary valve, unless it's absolutely pristine on echo and at operation, that the pulmonary valve should be intervened on simultaneously, and other valves and procedures as needed. You know, if they have a PFO, that should be closed, and they may have other valvular conditions. And again, these are from the same two groups, left the UK, right the US, and just showing examples of what other things are done in these patients. And also, if we look at the US data, just wanted to point out the predominance of bioprosthetic valves that are used as opposed to mechanical. And that's really the point of the next slide. You know, which type of valve. The graph, the survival curve on the right, again from the US groups, would indicate that there's not a significant difference in survival, although small numbers. And certainly at GenesisCare back in 2018 in Tampa with Jonathan Strasberg presenting, who obviously is quite an expert in neuroendocrine, being the lead author of the NETA-1 study, which is the first one ever to show a mortality benefit with lutate therapy. You know, from his talk, certainly said that at Moffitt they're moving to bioprosthetic, and the disadvantage is that there is thoughts it can be affected like the native valve, although that's not necessarily been reported particularly in the literature, but perhaps more a theoretical factor. But the major disadvantages of mechanical valves are anticoagulation requirement in obviously in patients with cancer, and liver mets not so good, and also mechanical valves in a tricuspid position, of course, have a significant thrombotic risk, and in the carcinoid patients considered to be about 4% per annum. So the move would be to bioprosthetic. But what are the outcomes? And the graph on the left is again from the US group, and this I'll just walk you through it because it's I think it's important. It splits it up into decades or thereabouts. The blue lines or the whatever the columns show the number of cases operated. The red lines the 30-day mortality, and the yellow line is the trend over the 30 or 20 years of this graph. And what you can see is in the early days, 15 to 20% mortality with small numbers, and that's steadily declined in this experience to under 5% from 10 years ago data now, to be fair. And the reasons for that are probably multiple, and include as I mentioned before, the somatostatin type drugs, the analogues came out in the mid-80s, the whole issue of carcinoid crisis, which is a big risk for perioperative mortality, was not as well dealt with in those early days. That's now, that risk is declining, and obviously this centre has a lot of experience, but you know, the data for non-cancer patients is often quoted at 10 to 15% mortality in some of the older literature for tricuspid valve. So there's just that general, there's always been that general reluctance by cardiologists and surgeons to tackle these. And I just thought I would compare this large group of experience from the US to a German group, which published just recently last year, with just 6 patients. So 2 patients a year being operated on. They had 1 death in the perioperative period from a carcinoid crisis. 1 patient a year later needed reoperation for what was an attempted repair of the valve, which failed. And not much of the literature would suggest trying to repair the valves. And then 1 died of disease at 18 months. And so at 30 months, the 1 that didn't die of disease or have the carcinoid crisis were alive and had New York Heart 1. So, you know, the concern is, of course, in inexperienced centres, they have a much higher mortality. And I guess that's an issue, particularly dealing with things like carcinoid crisis. And this is complex and is why expert teams are required, and anaesthetic management and perioperative care is important. And this is another group from the US. This is published in Anesthetic Journal, and I won't go through it, but it's essentially outlining the Mount Sinai algorithm for managing these patients in a perioperative sense. And hence, this is one of the big benefits of the specialised centres. So the mortality, not inconsequential, but I remind you again that with severe carcinoid heart, mortality is bad. And as Joe Carver mentioned, certainly waiting till these patients are highly symptomatic portends a bad prognosis. Nearly at the end, but I just thought I'd put this in. So are there novel approaches, as our structural colleagues are certainly now putting in TAVRs in the aortic position. There's MitraClip, there's the High Life mitral valve percutaneous replacement. On the right is the Edward Sapien up the top, percutaneous aortic valve replacement. Can be put in the pulmonary. There are case reports of it being done. So my structural colleagues tell me the most difficult thing about it is to make sure you turn it the other way around when you implant it, because it goes in differently to the aortic. Below that is the Medtronic Melody valve, which is the particular one's actually been designed more for conduit insertion in congenital heart patients in the pulmonary position. So there are some options there. And on the left is actually a new technology that's come from an Irish company. They've actually just implanted their first human case in March of this year. And this is, there's a video if you want to go watch it on the website. I won't try and explain it too much, but it apparently is a 5 to 10 minute procedure. You fix with scaffolding in the SVC, and then this whatever that mechanical aspect is sits not fixed into the tricuspid valve, but somehow the valve closes around it and then makes the leaflets shut entirely. And so there is apparently in the one human case, and obviously presumably it's been trialled in animals prior, it was successful. But, you know, I think as we go on, percutaneous options will certainly, I suspect, make a difference to our eagerness to treat these patients. So next steps for Mrs. TU, well, this is what I've done. Well, what I'm done and going to do, I have sent her off for a cardiac MRI. I've repeated her 5-HIAA to doing her NT-proBNP. On Dan's suggestion, I am definitely going to send her off for, or do a 6-minute walk, or maybe get her to do a stress test. And I'm going to have a good chat to her oncologist about her prognosis and what other options for her neuroendocrine tumour, and certainly discuss with the cardiac surgeons to make sure we find one that is comfortable at operating if we do decide that at some point in the future we will. And I suspect that if her disease has progressed like this in 12 months, and I'm certainly going to watch her more carefully than 12 monthly. So thank you. That's I have run a bit longer than I thought I was going to, but I guess any questions or any discussion?
It's a fabulous presentation. I really enjoyed it. Thank you.
Yeah, hi. Can you hear me? I can.
I've got a fair bit of echo, so then thanks, Dan, for the feedback. Hello.
Yeah. Somehow we got this bad echo all of a sudden. So thank you so much. And yeah, I think the whole TAVR idea is probably not viable right now. They have suggested that you put the valve in reverse, and as you mentioned, and I have experience with about 5 patients in which they did the TAVR procedure and flipped it around, and none of them did very well. So I'm not sure I would be a proponent of that.
Okay, Dan. So you're talking about when they put the TAVR in the IVC to prevent the abdominal symptoms?
Yes.
Yeah. So no, I was talking more about actually putting it in the pulmonary position to actually relieve the pulmonary stenosis or pulmonary incompetence.
Yeah, no, I think that presumably would be pretty successful, I would think, but the whole flipping the TAVR around and putting it in the IVC
Yeah.
as a strategy to manage the tricuspid regurgitation was, I think it was kind of a dumb idea, but then also I think it was highly unsuccessful in my experience.
Yeah, and it makes sense that it doesn't work to as first principles because the volume load is not really greatly improved because the tricuspid valve is still severely incompetent.
Can I comment? I think one of the issues would be the role of the pulmonary insufficiency in causing the ventricular dilatation. I had a case a while ago with a hepatic tumor, cancer, and she couldn't be operated because of tricuspid regurg, but she had severe pulmonary regurgitation as well due to a failed insufficient pulmonary bioprosthetic valve. We replaced the pulmonary valve and her heart got smaller and the tricuspid valve came more together and regurgitation became good enough that she could have undergone a liver transplant, which was the whole point of that. She did not have carcinoid. But I just wonder what the role would be of a simple percutaneous valve replacement with the Melody or the Sapien, which are known to be useful, and perhaps get the heart to get smaller and reduce the tricuspid regurgitation as a temporizing measure if somebody is not felt to be a good surgical risk. I mean, it's kind of something you have to think long and hard about in this situation, and may want to look at the tricuspid valve specifically to see how much of the regurgitation is due to ventricular dilatation and how much of it is due to pathology of the tricuspid valve itself. Any comments on that?
Yeah, so in this case, I agree with Ron. If you look at the tricuspid valve, it doesn't look particularly carcinoid, which is usually matted up and totally immobile. I think that the problem for her is the PI, and if you look, the RV is dilated. I think that's the issue more than the tricuspid regurgitation, and that she really might get better by fixing the pulmonic valve.
I mean, I think that would, I mean, again, it makes sense. I mean, both valves are obviously causing an issue. And fixing one, and if the pulmonary is the most severely affected, may be enough. And certainly if it can be done readily, percutaneously, noting the, we are, really there's nowhere in Australia that's a high volume sort of carcinoid heart center that operates frequently. So, we're not, we can't just send her somewhere where they do 60 a year or something. So that may be a viable option actually. And I thank you for that suggestion.
Well, and I think the other part, Daniel, is that, so I've been at a number of different institutions, and one of them, I would say nobody was really all that comfortable with doing, difficult valve replacement surgery. And then the next time I went, to a different institution where there was, really a true expert in terms of valve surgery. And then now I'm at WashU, and I think there are maybe one or two surgeons that are pretty good or pretty confident about, complex valve replacement type surgeries. So I think it really does matter about your institution. And I think that, doing some complex multiple valve replacement surgery or some combination of procedures, it's not for the lighthearted, and it's not for your fresh out of training surgeon.
Would agree. Any other questions or comments?
No, this is super. Thank you so much, and so glad to have the multidisciplinary input. That's always welcome. We really appreciate it.
Yeah, we live cardio-oncology. All right, all the best, and thank you for the opportunity to present.
This was a terrific talk. Thanks so much.
Yeah, thank you,
Thanks,
Daniel.
Dan. Thanks, everybody.
See ya.
Live from NPO News, I'm Corva Coleman.
Congratulations, thanks.
Bye.
Question.
Thank you.
Goodbye all.